me about do I have any publications or books or whatever. This is going to be the title of a book full of clinical cases. I'm gathering cases at Jacksonville University. Some of my residents are putting some implants in. We're doing different stages of treating lateral agenesis like cuspid substitution. I'm going to have everything in the book just for the lateral agenesis and working in the aesthetic zone. My implant can also be used in the back of the mouth as well, so it's not limited to just the front. Last night I looked up Brannemark, because I think I pronounced his name wrong last night, and it was interesting. I read that he had a lot of trouble having people believe in him when he first came up with this idea of titanium is a good thing to use to support the teeth. And so the first case he did was in the 60s, and he put implants, or I don't know if he did or a dentist, and he put the implants in a patient that needed a denture supported, and it lasted 40 years until the patient died. And my mother's had implants in her head for 40 years that are machine polished, so I think my system's going to work. These are my two boys, and I'm not proud of them. This is the orthodontist here. This is the implant dentist. And we had a crazy photo shoot for our practice. So this was a photo where we were supposed to be the three men in black from the movie. So we had our 3D glasses on. So then I went and photoshopped out the background and put some 3D images on our eyes, because this is the way we all will be looking at dentistry in the future. And the future is here. A lot of us are already doing this for a lot of our cases. Also, I mentioned a website called Dental XP, so I put this slide in last night so you can see what I'm talking about. I called last night and asked for Eddie Salama, this guy right here. And the guy you need to ask for is Tyler. I didn't know that Tyler was still there. He's been there like 5 or 6 years. This is a fantastic source for surgeries, for orthodontics, for anything you want to see before you do it. You can watch 4 or 5 videos of the procedure you're going to do. If you're going to do a sinus lift, there's several different ways of doing that, and this is a great site. So we're going to have a workshop here today, so I'm going to present this case. And I want the audience, this very large audience, to give your opinion on what you see here. So who wants to start? Do we have a mic that we could use? Thanks a lot. I think we just turn it on and hopefully it'll work. So you're going first. What do you see in this case? Not working. Just come up and talk loud. Hey, good morning. So what do you see in this case? What do you think is happening here?
It's a midline diastema because of the frenal pull, linear frenal, but I don't see a frenal pull.
So you think maybe the frenum could be contributing to the spacing here in this patient?
Because of the maxilla is much bigger than...
Okay, so we might have a prognathic maxilla. Okay, so we see interdental spacing. Good morning. So interdental spacing, prognathic, mandible, midline I think is okay. And then the frenum could be contributing to this space. Okay? Anybody else?
Maybe we have loss of the posterior anchorage with perio problem. That's
okay. So perio problems. Okay, that's a good track to go there. What is this condition called in older patients when the teeth just start to, spontaneously space? What's that called? Periodontal migration. Okay, so this was something when I first saw this patient come in, perhaps she had periodontal migration. So here's the records, the CBCT, And what do you see on the panoramic, reconstructed panoramic view here? What do you see? Okay, you see some bone loss? Where? Generalized? You see any localized problems? Between 8 and 9? Okay, now I'm an orthodontist. I go 1, 2, 3, 4, 5, 6, 7, 8, or I can do 1 through 32.
Yeah, 19.
Okay, 19, thank you. Okay, so right in here we see something happening. Okay, is that tooth root canal treated?
Yes.
Okay, so maybe it's the root canal gone bad, abscess. Okay. Okay. What do you see right up in here? Resorption. External resorption.
Most probably it's external. Most probably it's external absorption.
Yeah. So if you see this in your practice, the patient presents, what are a couple things that go through your mind initially with the prognosis of 8 and 9? You think we can save it? Save these teeth? Okay. So I don't think we save the teeth in this case. I know the answer, but these teeth are compromised to the point the patient's going to probably lose them. Now, when the patient loses these 2 teeth here, that's going to probably create a spacing problem as far as what can be done, whether we're going to put implants in, put a bridge in. So maybe the orthodontist might be needed in this case. What do you all think? Yes? Okay. And maybe we need an endodontist or somebody to remove that tooth. In the U.S., endo is less and less recommended now. Most of our cases, we go right to the implant because it has a better longevity, because you can treat a case endodontically, and then maybe 5, 6, 7 years down the road, you might have to do an apical on it or retreat it. You have to put a lot of money into that one tooth, so sometimes the implant is the best option. Good morning. So we have to look at the cost to the patient, and probably, I think we recommended an implant right there. So I think that's one of the things that we did in this case. But I do know the answer. So is there any other comments on what we would do or what needs to be treated in this case? Somebody mentioned periodontal problem. Do you see a periodontal problem? Well, I switched by accident, but did you all see a periodontal problem up in here? Okay, so there's a periodontal problem up there. We happen to have a nasopalatine cyst up here. Now, we sent this case to a radiologist for a read, and a report came back, and she did not put on there was a nasopalatine cyst. But when we went in surgically in this case, there was a nasopalatine cyst. So I called her up and I said, why did you not identify this in your radiological report? And she said, well, it has to be over 10 millimeters for her to call it a nasopalatine cyst. I think it was like 6 or 8. It was pretty big. So that was something, was a learning experience for me. And my son, Jonathan, actually read this x-ray. He used to be my clinical coordinator when he first got out of school. So he practiced and learned orthodontics with me for 2 years and ran my clinic. And he was the one that grew up on the video games and really knows how to read x-rays. And so he taught me. And he's the one that picked up a lot of this information. So anyways, we have an abscess number 19, we have external root resorption, and we have periodontal problems. So those are some of the things that we see there. When you all do CBCTs, do you all send every case out for a radiological report? Do you have to do that in your countries?
Usually it comes with the report.
Okay, so you send the patient to a center, and they're scanned, and then you get a report with it. Okay. In the U.S., we don't have as many of those centers anymore. California used to have the most number of centers because the doctors, they could not afford to rent space in San Francisco and Los Angeles, so they didn't want to have an x-ray area, so they would use an outside lab. And it's nice when you get a report with it. When I first started doing CBCT dentistry, we were all running scared that if we didn't do a report, we opened up ourselves to lawsuits, because there might be some pathology we'd miss in the brain, like a brain tumor or calcifications or carotid occlusions and so on. So I went to school and learned how to read the x-rays and find these things. I made a spreadsheet of all of the possible problems there could be, and it's like 200 different diagnoses. And I'm sure there's more. I'm not a radiologist. One of the things that I am urging right now is that we don't take a large field. I was taking large fields on most of my ortho patients, so we take a focus field. So for our American Board of Orthodontics, you have to have a cephalometric x-ray to trace and measure all the angles. So we use a 2D machine to get that view, and then we take a 3D scan that we make a Panorex, and then we're able to see the bone on both sides of the root before we move the teeth. So that's the protocol that I think, I know we're going to be doing that at our university. I want to have a 3D but a small focus so I don't expose them to too much radiation, and then I won't be responsible, hopefully, for any pathology I miss above the Frankfurt horizontal. That's about the area that we're going to go. Okay, so we looked at that. And so what is your treatment plan? What will you do for this case?
Start with the cleaning.
A deep cleaning?
Deep cleaning.
Okay. Perio first?
Yeah.
Okay. Good.
And then we'll do assessment what the teeth can be
Saved.
and what can be removed.
Good.
And we discuss this treatment plan with the patient, because some patients they refuse to remove teeth even if it's compromised.
Yeah.
They said if it can be saved for 3, 4, 5 years, they accept this.
Yes. You know the concept of using hopeless teeth, where you can diagnose a tooth is going to have to go, but you want to do an orthodontic movement, and for mechanical anchorage purposes, you leave the bad tooth in there, unless there's a big infection. And you may have to go and do a root canal on teeth that you want to distract. Maybe you want to build bone with the teeth. We learned so much yesterday, thank you, on all the different ways you can move teeth to make bone. So I really think that orthodontists should be grafters. You know, I think we have a whole new specialty. If the implant dentist wants us to build some bone for him, don't send them to the periodontist, send them to the orthodontist, right? Okay, so there's a whole new specialty. So anyways, the treatment plan, first of all, get the perio knocked out, then make a decision on any teeth that have to be removed, and then are we going to do implants, are we going to do bridges, are we going to have to do any orthodontics?
Yes.
Yes, to all of that? Okay, what's the sequence? And what would you do?
After you mean to close the space?
Okay, you want to close spaces? If we're going to be extracting 2 teeth, we're going to have excess space.
At that time, we will use implants.
Okay, would we put the implants in right away? Would we bone graft? We have a nasopalatine cyst and a lot of bone loss up in that area when we got in there surgically.
We need to put one.
Okay, so we might have to do a bone graft up there. Okay, socket preservation. Now we could have distracted these bad teeth, the bad teeth. We could have orthodontically moved them down a little bit and built some bone. So that's something we didn't do, but that's something that we could have considered. So there's going to be some orthodontics involved, right? Yes. Okay.
Yes, because we want the teeth to have a good space with a smile design.
Yeah.
Right now,
Smile design, right?
yes, I want to know before
Yes.
the space for the one and the second inside.
Yes.
So I move and after I take out.
Whenever you do a denture, what are the first 2 teeth they usually set to design the case? 8 and 9, right? They put the 2 centrals in. and then they go from there to set the case up. We should do that orthodontically, and that's where Christian Coachman's digital smile design comes in. Or you can send off to a lab and have a wax-up done. And we just happen to have done that. Now, I didn't know about Christian Coachman. This case goes back about 6 years, and I hadn't met him yet, and we did this one with a lab that waxed it up. And I didn't do this for my orthodontic cases ever. I had an implant dentist that came into the practice, and he taught me so much. He was a cosmetic dentist, and he did smile design with a wax-up. And that's where I kind of learned. I learned so much from him on using. I know about the golden proportion. We talk about it all the time. We talk about balanced faces, but we don't use it. Orthodontists don't use that. And I think we should be using that before we even move a tooth. We should know if we have a Bolton discrepancy. We should know if we have small laterals that need to be made a little larger. And so this is a great teaching case, as you'll see.
Excuse me.
Yes.
The teeth was wide.
Yes.
And the space is wide.
Wider.
So do you think we can put 4 teeth here or
Put extra teeth in there?
after we make extraction?
Yeah, there's
Space
two
is-
teeth had to come out.
The space is large now and wide.
Yes.
If we put 2 teeth, we must make diastema between the 2 teeth.
No,
Because we can't make big teeth.
that's a very good point. But what if you have laterals like these that are not that big compared to the centrals? Maybe you can make the laterals a little bigger to take up some of that space. We need a smile design is the take home for everybody. Smile design, okay? And that's what we did. So here's Miss Heather after we had her teeth removed, and she was so embarrassed to lose teeth. She took very good care of her teeth. You saw the first picture. She had stippling of, nice pink gingiva. Everything looked so beautiful. And I always call these cases the Titanic because there is an iceberg under you don't see. And so, she never thought she'd ever lose any of her teeth. So from a psychological point of view.
How do you convince her that you have to remove?
It is so hard in these implant dental patients that come in with they take care of their teeth and they have, a situation like this that they're not aware of. You have to be very gentle in explaining things to them, and it's almost like giving somebody a diagnosis of cancer, but you say, don't worry, it's not cancer. The world's not going to end. We can make it even better for you. And so she was not married yet. I think she's married now, but her boyfriend was a chiropractor, so he was real involved in what we were explaining, and so it was a good experience for us when we had to tell the patient that she had tooth cancer. And so it worked out fine. She was extremely happy, and we worked with her for almost a 2-year period because we had to do ortho and some prosthetics and bone grafting, some perio treatment. So you'll see all this.
You make implant here or normal bridge after smile design?
I can't tell you. I'll tell you after we see some of this. Okay, are you familiar with the LANAP laser? Laser-assisted new attachment protocol, or I forget what the P stands for. When Dr. Williams, my teacher, came, the Space Coast economy went down because they shut the Space Center down. He was in Port Orange, and he had a very high-profile patient. He did mostly implant surgery and major cases. So what are the first things in a recession that people don't spend money on? So he basically had to go out of business, and then I brought him into our practice. Right now, he's in Palm Beach, and not last month, he didn't do as well last month, but the month before, he collected $219,000 in surgeries and implant procedures. He is like a super dentist. He doesn't ever sell anybody something they don't need, but his procedures are very expensive. And it was very nice having him in our practice because we could, we didn't do that many cases because people didn't have the money, but the people that did, we really learned. And this young lady had a very rich boyfriend, fiance, so she was able to do all this treatment. But anyways, the LANAP, I don't have enough time to go into this procedure, but Sjogren, who's from France, I'm sorry, not Sjogren. I'm getting ahead of myself. That's PRF and PRP. This was invented by a company called Millennium, and it's a specially tuned laser that goes in and does a non-invasive procedure where it basically ablates the whole periodontal attachment all the way down to the apex of the tooth. You go in with a scaler and you clean it, because it basically just fillets it open, but you're not cutting it with a knife. You go in, you clean it out really well, and then there's a setting on the laser where you go back and it creates a little blood clot and it seals it up. And you just leave it alone. You don't probe it, you just leave it alone, and new bone is regenerated in some of the cases, not every case. So we did the LANAP procedure. When I go into detail on this case, this was a board case for me to pass the initial level of being an implant dentist. And so this was the report that we had to write up for the case. So this was one of my cases I had to present in Chicago. And get through that. This is the radiology report. I pointed out that the radiologist disagreed with us that that was a nasopalatine cyst. And Linda Otis, University of Maryland, she's like one of the best radiologists, so if you ever need a good report, I highly recommend her. And whenever she does her reports, she'll go ahead and take screenshots and include it in the report. So whenever I give a lecture, I just take from what she has presented and include them. And if there is a pathological area, she'll give you serial slices of the area so that you can look at it. Okay.
Okay, well here we have our patient.
Now I need
header,
volume on
and
this here,
we're
so let's see if we
using
get this
some
working.
adjunctive orthodontics to prepare the implant sites for teeth numbers 8 and 9.
wish he was
We
here to
have
turn the
used a
volume.
lab-made index, which is made out of a polyvinyl material, open heather, and we can put this index in to see exactly where we are. You know, we have orthodontically wanted to move this tooth mesial, and also the other lateral, number 7, we wanted to move it mesial. Well, I already have accomplished getting number 10 exactly where it should be. There was a wax-up that we did that showed the ideal proportions for these teeth, and so we're using this as an index so that when I'm orthodontically moving the teeth, that I get them precisely placed so that we can get the implant or implants in there, and then the final crowns will be exactly as the diagnostic wax-up. Also, while we're orthodontically treating her, we put some Pontics on the arch wire. We also have some springs that, you know, keep us from moving too far. And today we took an impression for a flipper because we're getting close to being finished, and we want to maintain this space being open between numbers 10 and 11. And then I'm going to put some active coil here today between teeth numbers 6 and 7 to try to get a little more room there to create the ideal space. These Pontics were made small on purpose so that we had room for the teeth to...
Okay, I'm glad that stopped so I can kind of point out some other things. Usually when I give a talk, I have HD and it fills a big area, so I hope you can see some of these little panels that I want to go over. So anyway, she had the initial problem here with it looked like periodontal migration to me. We did a analog wax-up instead of digital wax-up. And then the lab makes a series of different devices that the cosmetic dentist uses for positioning the teeth for final crowns. I used it as the orthodontist. It was really great to have this. Also, they'll make like a smile, like a smile design wax up like an essence, and you just fill it with material and put it on the teeth, and it creates a snap-on smile. So we were able to simulate with this patient, you know, how she was going to look. So this was part of the communication. She was so happy when she saw this. When you showed her the wax up, oh, my teeth are going to look like that. So these are the ways you communicate with the patient to make them feel comfortable that you know what you're doing. Even though at the time I didn't know what this area here, this is something that I learned as an orthodontist from the implant dentist. You can actually condition the tissue where the final crown is going to be. So you can use what's called an ovate pontic, and you can trim it each time the patient comes in or add to it, and put the retainer in and put some pressure on the tissue there, and they wear it. And they're going to wear it because she has no teeth, but she doesn't wear it. So we were training the tissue right here to where we were going to have the implants project, and the trajectory of the implant we were determining by using the ovate pontic.
Okay, well, here we have our patient Heather, and we're
What I did is I blew this up in case you all couldn't see it. I don't have enough time to play it again for you. So I mentioned to you digital smile design. If you go home and search on the internet, go to YouTube, get Christian Coachman's videos. Did you watch any of those last night?
Yes, sir.
Did you not love, I mean, this is like Hollywood. They do these video productions where the patient is filmed before, and most of the women that he highlights are beautiful to begin with. They don't even need to have, you don't think they need to have their teeth changed. But it's just amazing after you see the digital smile design, and then they put the snap-on smile in, and then they do the veneers, how great these cases come out, and they use it for marketing their practices. So this was a site here that I'm going to be working with these people because I want to bring this into orthodontics. That I'm going to propose to this the CEO of the company that we do a Bolton analysis, and we also do a golden proportion analysis before we even move the tooth. I want to know those things so my residents will be thinking of ideal proportions and maybe working with the prosthodontist or the implant dentist to help out with making these cases perfect. So this just shows a little more of the ovate pontic. These are some of the items that come from the lab. You can fill this with a material called cinch and stick it on, and the patient will see what their smile is going to look like. So this is just some different stages of her treatment where we're preparing cut the laterals to be in the right position. We jacketed these teeth. Now I was working with Dr. Williams on this case, so the prosthetics I left up to him. I just did the implants. I had to put these implants in, and he was holding my hand when I was learning how to put implants in. And he made me a couple guides that if you all ever want to put big boy implants in, I don't know if we have time to get through it today, but he really helped me out. Here it is. This is what I wanted to show you right here. He made me an Essex that gave me the palatal limitation of where I should put the implant in. And then the arch wire gave me the labial limit. So when I went ahead and did the procedure, if I got it between here and there, I was probably going to have the implant in the bone. So that was a great help. And I've had other cases where I've made an Essex and just taken trim it. I did a case where I had to put 5 lower implants in. And so we took his denture. We duplicated the denture. Then I cut back the lingual so I could not go too far to the back. And of course I didn't have an arch wire in that case. But I had my whole staff was there, my hygienist, Dr. Williams, and they were holding my hand as I'm putting these 5 implants in, making sure they're all parallel. And I'm not going to do that again because I'm sticking to the small implants, but I had to do this to go through all that certification work. So if an old guy like me can put an implant in, you guys can too. So the orthodontists, if they wish to do this. I can go into the detail of the lab analogs and everything we had to do with peak abutments and so on, but let's get through this. This is the CBCT showing in this view that we still had a nice buccal plate area here, and then this is the trajectory here. The implant that I designed, I like to have the abutment on when I put it in, because that gives me my trajectory. The trajectory should come behind this tooth. I'd like to have them tilted back towards the palate. I want to have as much buccal plate as possible. And why do I do that?
Absorption
Changes.
occurs with
Growth changes. Yeah, aging and growth changes. Okay, that's why we do that. Now, one of the things as orthodontists, we all know the interincisal angle, right? Between 125 to 150 135, 130 is good. This is what I use when I am planning a case. I measure the interincisal angle of the teeth that are adjacent to the implant. And sometimes I'll average that number, or I will duplicate that number. And yesterday I passed out a little guide on a stick. So I put that guide up there, and I'll mimic the tooth angle that is the best for me putting that implant in. And my little guide is designed as exactly 6 millimeters in diameter, which is the smallest site that I want to have at least 6 millimeters before I put my implant in. I do have a small side which is 3 millimeters, so I can use that for a drill guide if I need to. If I have to actually squeeze the implant in 5.5 width. So these are some guides when you guys are putting in anterior implants, if you ever want to do that when you grow up. Okay, I was mentioning Sjogren. This is material that we take 4 vials of blood from our patients. Are you using the PRF and PRP? Huh? You're not doing implant surgery yet. Okay, you will be when you go home.
We
So
use this.
you use that. Okay. This is a fantastic addition to bone grafting.
And I use it to the face.
Yeah.
PRP.
Oh, the PRP, yes.
Yeah.
Yeah, in fact, it's funny because my wife was starting to lose a little bit of her hair up here. So they have a thing where they needle the scalp, and then they spread PRP on it.
Yeah.
So she couldn't get any doctor to do it, so I was signed up to do that. And then somehow she went to a doctor and they gave her some more meds, so she could try the meds and see if that would work. But I'm prepared to stick needles in her head and use PRP on her if I have to. But the nice thing, when you spin down the blood, you get
Like something huge.
this is like a fibrin clot.
Yeah.
It looks like a booger, okay? And then this can be put in the PRF box and you can flatten them out and make membranes. You can use this with collotape or collar plugs or whatever for bone grafting. You can also mix bone right
It is
into
better
the
than
PRF.
membrane.
Hmm?
It is better than membrane.
It's better than a membrane. It's the patient's own biological material concentrated with healing factors.
Growth factor.
Growth factors, yeah. And we use, we give them 2 shots of dexamethasone, phosphate, acetate before we do this, one in each shoulder. And one is a short acting in a day or so, and the other lasts up to 7 days. When I lost a tooth because it fractured from old age, my son and Dr. Williams put an implant in. In fact, when they anesthetized me, I took my tooth out myself the rest of the way, and they got it on video. They gave me the shots of the Dex. The next day, I felt so good, I went out and ran after I had this implant stuck in there. So that works out great. So most of our patients feel really good the next day with the procedure that we use. They heal very fast with the PRP.
Yeah. I'm interested.
And so the patient up. And the key to these cases being successful is good primary closure. That's the one thing whenever the doctors are training, they don't put enough stitches in. It'll open up. Once that happens, you lose the graft. So that's the take home on if you're ever going to do these procedures. So this is what the membrane, we use it as a membrane. There's bone underneath this. This was an oral surgeon that this 2011 emailed in. His name is Dr. Kim. First name is King. And we had a study club, and there is a company called Harvest that sells you this machine to do the spin down, and they sell you all the parts to do this procedure. It costs about $100 to $150 for all the parts. We went on to eBay because Dr. Williams does so much of this, and for $5 per patient, we ordered all the supplies we needed on eBay. So if anybody's going to do this procedure, you email me and I'll give you the source of being able to do these procedures for $5. Okay. So anyways, this is just showing trimming the retainer. You can do ovate height on your retainers to sculpt the tissue. So whenever you're working with an implant dentist doing orthodontics, you can sculpt that retainer to start forming your gingival tissue orthodontics, and this is I can go through this in about 20 minutes. I'm not going to do that. I'm going to just say there's different designs, and they all have different uses in implant dentistry. Are you watching the time, you guys? Because I don't want to go too far over and
Take your time.
and
It's
not
very
get
interesting.
So anyways, this is some of the prosthetics that we did as far as getting the patient ready for the crowns. We used some temporary crowns and we sculpted the tissue to where it looked like it was sunk in. And when we made the final crowns, it looked like it was growing right out of the tissue. And it's just amazing, thinking of an orthodontist being able to sculpt the tissue as well as move the teeth. And we should be doing that for our implant dentists. PICA abutments is a special plastic developed in LA at UCLA. Now, this is the case with the final crowns are up top, and then the crowns down here. These were we were still sculpting tissue with plastic PICA, but then we had metal abutments. Yes, sir.
We put the two implant, we make orthodontic treatment to move the lateral,
Yes.
to make the space
Ideal.
ideal for the two central.
Yes.
Instead of preparing all this lateral, why we don't put the lateral veneer? The veneer,
Well,
very less preparation.
I agree. Dr. Williams wanted to tie these teeth together somehow. I don't think he did tie them together. He decided that it would be better to do the crowns, so we did the crowns. After seeing Christian Coachman's material, they're mostly veneers. And so I think less invasive procedures, I agree. I'm going to criticize how this case
And
looks
we
at the
put
end.
implant
Mhm.
not to prepare the teeth, not to make the teeth small, not
Yeah.
to. So here we put implant, and the other teeth, no need to prepare anything.
Well, the problem was we had such a big
And
space
for
that we
aesthetic,
had to
we
move.
put veneer also to be beautiful.
Well, I still had to move those laterals even to do a veneer on this. He prepped the back of the tooth as well as the front for a veneer. And I agree we could have been less invasive, and there are some things on the case that I wanted you all to look at and tell me how you would make it better. So here you can see the implants in. We went ahead and got an implant in this area eventually, as you can see here. And then this is the final case. Now this is just after we put them in. The tissue relaxed and looked a lot better. The tissue was swollen here. And so I don't have the final picture after everything's settled. But I want you to take, okay, here's a dieback phenomenon that I wanted to point out to you. Whenever you put an implant in, and the platform switch thing I talked about yesterday, the bone will just shrink back about a millimeter to a millimeter and a half, and then go very slow from there. So you almost plan on that happening. When they did platform switched implants, then the crescent bone tended to stay there. There was less loss of bone in that area. But we did have dieback on this patient in a couple areas. If you could see it close up, you can see that the bone is back at the second rib. Okay?
Resorption.
Yeah, it's a little bit of resorption. It's called dieback. And then the Lanap site, that picture up there was not the after. Okay, now here is the before and after. I want you all to tell me how we could have improved the way these teeth look. You're probably the expert because you do more prosthetics than the rest of us here. So what would you do to make these teeth look better? I know you do veneers here.
Yes.
Okay. What about the axial inclinations of what the lab is here? The tip of the crowns.
It is done, it's fine.
Is okay?
Yes.
Okay, from an orthodontist point of view, where would you put these? Are these okay as far as the axial inclinations, the tipping of the crowns?
It's little outside.
Hmm?